Dr. Melanie Bone, who's going to be talking about the role of cannabinoids in senior health and well-being. So without further ado, I'm going to give the microphone back to Dr. Bone.
I guess we don't see a lot of pregnancy in an old age home. Okay, so my other hat that I wear is I am medical director of cannabinoid therapies at Morse Life, which is a 5-star gold seal teaching nursing home, the only one of its kind in the state of Florida. And interestingly, the legislature passed a law that allowed them to have a multiple caregiver situation in order for us to do studies there. But given THC and its status as a Schedule I, I have never been able to do a study there, despite trying since 2019. Okay, this is going to be sort of quick cases. I like to do things in a very clinical approach. 4 really common issues that we have at Morse Life that we try to implement cannabinoid therapies. The word there, try, is very important since the average age at Morse now is 91 years old. And it is really difficult to get some of them on board to even consider trying, no matter how good I tell them it might be. Insomnia, appetite, pain, and dementia. Those are the heavy hitters. So let's just look at my buddy, Ms. X. There she is at lunch, falling asleep into her soup. Why? Because at night she's in front of the TV and she falls asleep just fine. But then guess what happens? She wakes up like 2 hours later, she has to move to the bed, she can no longer fall asleep, or if she can fall asleep, by 3 a.m. she's wide awake. And so she was told, take some Ambien, it'll be really good for you. And she wants a second opinion on it, and she wants to know maybe about this stuff called cannabis. Typical of my senior patients, she has multiple other problems: hypertension, type 2 diabetes, and hypothyroidism, for which she takes lisinopril, metformin, and Synthroid. This is a really typical patient, right? I'm sure everybody sees this patient. So what do you think? Is cannabis the right answer for her? Well, maybe, maybe not. So firstly, I would want to rule out a blood sugar issue as one of the reasons that she wakes up in the night. You know, if she takes her metformin, hasn't eaten a good meal, and she drops her blood sugar and wakes up, cannabis is not going to cure that problem. But if we're sure that her sugars are okay, I have no problem with the initiation of cannabinoids. Now, in someone at this age, with these medical problems, we usually go with the adage of CBD first, okay, for a number of reasons. But it probably will not help with initiation of sleep. I don't really believe it helps decrease the latency period. I think THC does that more effectively. And for the patients who say to me, well, if I take this stuff, is it going to make me not breathe because I read you can die in your sleep from sleeping medicines? We say no. If anything, THC in particular has no impact. It may be better for sleep apnea, but cannabinoids in general are not going to impact your breathing. I believe that in women in particular, CBD can help them to sleep a little bit longer because I think it just downregulates their brain a little bit better, whereas THC can inadvertently wake up their brain. So I insist that for people who want to use THC to decrease sleep latency, they definitely have to be on some CBD. But in this population, I usually just start with CBD, and hopefully she'll enjoy a more prolonged and maybe better sleep. CBN, as we all know, has been touted as the sleep cannabinoid. I find it interesting because I swear at maybe the first one of these conferences or one like this, someone presented data about CBN, and I think the study had 15 white male patients in it, right? So I don't know that the data are there showing that it's efficacious for senior women or even senior men in particular. But it's touted, and it's hard to find products that are asleep now that don't have some amount of CBN in them. So I don't think it's going to hurt the person, but because at last check it was many $1,000s a kilo for CBN, you will always pretty much see it cut with CBD. And in true CBNs, if you look at their COA, it may say that it's all CBN, but a lot of it is not. And as we said, the THC component, and you can even get this from full spectrum CBD, which is what I use in this population, just that tiny little bit of THC can be effective in relaxing the muscles, inducing the sleep, and then the CBD can help to prolong the sleep. Okay, sometimes anxiety is a part of falling asleep because it's not only I can't fall asleep, but then I start thinking about the fact that I can't fall asleep, and then I'm worried about the fact that I'm thinking about the fact that I can't fall asleep, right? Okay, so you must get that brain to calm down a little bit, and I feel like, again, broad spectrum or full spectrum with that little bit of THC that will help to increase the efficacy of the product can be helpful. So at Morse Life, the way it works is I offer the patients a gummy or a tincture. They're not vaping and smoking at 91 in a nursing home, okay? So most of them want something sweet. They do not want something that tastes bad. And the other thing we'll talk about later is that drops, which I thought were going to be the be-all, end-all for this group, are not, because they don't like them. So you have to do a gummy. So I have a variety of what I think are good quality gummies, and I let them pick. Do you want sugar on the outside? No sugar on the outside. I helped develop one for seniors at Morse, and it has a combination of cannabinoids along with 1 milligram of melatonin, and I have them start on a half about an hour before they want to fall asleep. And we see how they do. They can go up to a full as needed. By the way, the ones I use are not particularly sweet because I don't want them just to be thinking about the sugar part. Okay, this is good old D. He's passed away, but he was an interesting gentleman. In his early life, he was very active, tennis, golf, and of course, he had happened to him what happens to almost everybody that I come into contact with in our care facility. He has severe spinal stenosis and osteoarthritis. He actually can walk, but it hurts so much after about 5 doesn't want to walk, so he sits in a chair all day, and we know how bad that is. But this is reality. This is what we see. And he also has a number of other problems like prostate cancer, which pretty much everybody who gets to this point has some element of prostate cancer. And so what has the physician I work with at Morse, or rather I work over here and they work over there, and there's not a lot of communication from one to the other because I'm just the cannabis doctor over here, and he's the real doctor. So this patient gets Vicodin, fentanyl, Cymbalta, gabapentin, and is on Spiriva for some COPD, okay? And this guy is still in pain all the time. There's a problem, right? I think he's a perfect candidate for cannabinoids, although I have to fight the real doctor on it. But how do you do it? Because he's worried about coming off his drugs. He's been on them for a very long time, and he's worried that if we just add cannabis, we're going to get into trouble. And I say no, and it's something I learned long ago at a conference, which is it's subtraction by addition. You add the cannabis first, and believe it or not, the narcotics start to fall away on their own. And he says to me, how do I do it? And I say, okay, we're going to start you again, CBD first, and I think we started him on like a 25 milligram gummy twice a day and went our way up to 50. And as it became, I said, you got to give it a good couple of weeks before you know it's going to work. And by about week 3, he says, well, I don't think I need so much. And I say, okay, well then here's what you do. If you're on a Vicodin, ask them to break it in half. Then instead of 3 times a day, go to 2 times a day. And ultimately, if you end up at half a Vicodin twice a day and no more fentanyl patch, that's great. I don't expect full replacement. I think that's a little bit unrealistic. But if we can get a 50% reduction, I think we're doing wonderfully. So the THC offers pain relief. Now, my problem with him is, and it's going to tell you, is specifically related to living in a care facility. Card. Why can't he get a card? What's the first thing you need to do? Supply a driver's license. Oh, I have my driver's license, he says. It's completely expired. It has the address that he used to live at before he moved into the old age facility. He's not willing to go, especially in the time of COVID, to the DMV to get a Florida state ID. So it's a hard stop at that point. Our only way around it is we use hemp-derived THC because it's the only way we can get it in, and it's still legal, and it's not perfect, and I have to know my purveyor very well. But I really started microdosing with these guys, and I will start as low as 1 to 2 milligrams of THC and creep my way up. And I find that, you know, a 1-to-1 that you can get to eventually works great with them. And they wean off their other medicines, no problem, by about 50%. Okay. This lady, this is so sad. 97 with a breast cancer, really metastatic, almost, they wouldn't operate, so it's almost coming through her skin. Very bad. And isn't eating, losing weight, and honestly, her family is more upset about this than she is because she honestly knows she's dying, but her family wants to keep feeding her. That's a really big problem with oncology patients and anorexia, cachexia, is that these people, it's part of their disease, and for some reason, we have this thing in our heads, if we can maintain the weight, they're healthy. And she's on tramadol, Zofran, extra strength Tylenol, Ibrance, Arimidex, and they want her to drink 3 Ensures a day, by the way. Have you ever drunk an Ensure or a Boost? They're terrible. And when you give a 90-something-year-old a chocolate milkshake for breakfast, they don't think that's great. So she is a great candidate if you can get it into her. So I believe that the important part of using both CBD and THC for this is that, remember, yes, THC increases appetite, but there's so much anxiety around the time of eating in these patients that they need CBD as well to help decrease their fears about not eating enough to please the people around them. And my thought is you go with tiny, small meals of things they like to eat. You have to ask them what they want. You can't tell them this is good and healthy and present them with some green shake that they have no interest in eating. Okay, you want a little bit of ice cream? You can slip some cannabis into their ice cream. There are just ways to do it that can be helpful for them. So this is what probably I'm most well known for, is using cannabis in dementia patients. So this woman who I lost track of was on our memory care unit. And you know, if you've ever been in a memory care unit, it's a very depressing place. They want you to think it's so inviting with an open kitchen and a beautiful aquarium. But honestly, the residents basically sit around all day, watch TV, have music entertainment, but it's just not, it's hospice for people with dementia is what it is. And a lot of them, as they fail to remember people, get anxious and they act out. They act out terribly. Well, this woman's husband lived on the independent living side, and he would come over to see her because he was a loving husband. But what happened was she would cry. She would cry incessantly, and then when he left, she would really kick and scream and hit and bite, and it was really bad. So they asked me in to see her, but not until my friend, the medical doctor, who doesn't like to ask me to come in until it's like we have nothing else to offer, already had her on antidepressants, anti-anxiety medicines, atypical antipsychotics. So she was on Risperdal, Trazodone, and Klonopin when I came into the picture. And I'm thinking, oh my gosh, he thinks my CBD is going to make a difference? I had no belief that it would help. It was like a miracle. We gave her a little bit of CBD, and literally within 2 or 3 days, she was smiling and clapping and listening to music. And it was so amazing. I don't know how it happened, but seeing it, and Sanjay Gupta came, and we were on the weed thing, and then every dementia family in the United States called me to know what I was using. And you and I know what happened. It's not reproducible necessarily. And I disappointed a lot of people. And it's really important when you're dealing with dementia that you understand there's no way to predict the outcome. In some people, it works really, really well. But then again, a neurologist whose mother was bigger, well, she makes me look big, throwing lamps across the memory care unit, we couldn't get enough cannabis into her to calm her down, and she tasted it in anything we tried to hide it in, and eventually we slapped a patch on the middle of her back where she couldn't touch it. I was like, yes, and it didn't work. And you know, she ended up just having to be medicated with benzos until she passed away. So you don't really know. They're a very vulnerable group of people. You want to have the buy-in of the adult children influencers to be sure it's the right thing, because if they don't want it, there's nothing you can say or do that'll work. On the other hand, if they want it and you don't think it's going to work, that's also a problem. So working in senior care is very challenging, but can be immensely rewarding. And this is just to show there are so many theories of how you get to dementia. They all end up at the same spot, neuronal inflammation and damage, which many of our prior presenters have pointed to the fact that can help diminish that neural inflammation. But since we don't really know the exact etiology, I don't think we know the way to cure it. We use a variety of different delivery systems, but in this group of people, it's hard. We use topical transdermals, but as we know, their absorption is not that great. And in a care facility where somebody has to administer things, having them put creams on is kind of hard because we like to do it on demand and that never works. So we often end up with orals and some sublinguals. If they're self-medicating, the drops are the worst because they don't want to self-titrate. They can't see the drops coming out of the end of the dropper. The drops on the bottom of the top of the bottle, and they don't shake it enough. They can't open the bottle. It's so childproof. So there are a lot of issues that we have to deal with. But the beauty is that I'm a senior, I'm on Medicare, and when it's my turn to be in there, I won't be afraid the way the current 91-year-olds are. So as our age group too moves on, a lot of these issues hopefully should go by the wayside. And we're hoping that we'll be able to study it. So toward that end, I've put in for a study actually utilizing hemp-derived THC in seniors in a blinded randomized fashion. I don't know if the study is going to go through, but if it does, that would be very, very interesting. Just lastly here, these are a few of the other problems we have. You have to pay cash. These people don't have cash. They can't get to a dispensary. They don't want to pay a delivery fee. They don't order enough marijuana to warrant getting delivery. I mean, the list goes on and on of how challenging it is. So when everybody says to me, it's so wonderful how the great things that cannabis can do for the ailments of aging, I say yes, but the reality, at least in a care facility, is very different than the reality of seniors functioning on the outside. Thank you.
Thank you again, Dr. Excellent. And you're right, there's a lot of obstacles in many parts of the healthcare system, and we see that many of us in the offices with patients that are either in facilities or even hospitalized. A lot of times it's a problem in the acute care setting in the hospital as well.